Right. So, although we're going
Mhm.
to only talk about this is iStent forum, so we're going to talk about iStent, and at the moment, the majority of the iStents that are being done are iStent Inject W, which is the second generation, but the modification on that second generation iStent Inject. It is actually a trabecular micro bypass. It's a very small device, the smallest known to mankind, and so is not just a MIGS, but also a micro bypass. So I would like to restrict to what has been given to me. Of course, you can talk forever, but I'm going to talk about the practical approach, how to adopt iStent into your practice. And these are my disclosures. We need to be aware of certain facts related to MIGS. First and foremost is that it opens up dormant collector channels, especially in the infranasal area. What do we mean by these collector channels? Basically, from Schlemm's canal, via collector channels to the aqueous veins to drain off from the eye. Therefore, intraocular pressure is limited by the episcleral venous pressure. Now, there is a pressure gradient in the eye, highest in the retinal artery, followed by the retinal vein, followed by intraocular pressure, followed by episcleral venous pressure, which is said to be around between 10 and 15. Who has 10 and who has 15? Very difficult to say. We presume that it is 15, and therefore very low IOP cannot be achieved. You want a gradient, you still have to maintain that gradient, and so a very low IOP cannot be achieved. Therefore, it is still considered to be a device that is effective only in early disease. That is mild to moderate. Why we say that? Because the channels, the collector channels can still be reopened if they are early glaucoma and if they've not received too many medications, for years and years. Again, the second thing that one has to be aware of is that open angle is mandatory for angle-based surgery. This could be open angle even after PI. That's not an issue. There are certain surgeons who do, including myself, goniosynucleasis followed by MIGS surgery, not necessarily iStent. And you have to be aware that post-operative management of that, it has to be very, very intense and interactive. You don't start any kind of dilating drops, and on the other hand, use pilocarpine, pretty quickly after surgery once inflammation has come down. One universal fact about MIGS is that it's overwhelmingly safe when you compare it to traditional bleb-forming surgery. The commonest complications that I have been able to take out, not only from my practice, but also reading literature, is the IOP spike. This is commonest in the first week, a transient hyphema with TMB, an overimplantation, or even an underimplantation, but an underimplantation can be managed pretty easily, or a blockage. So how you enhance outflow, how you open up the collector channels, look, an aqueous angiographic movie of a patient prior to implantation and after implantation, 2 iStent injects, how the dormant collector channels open up and allow aqueous to flow out of the AC. Another very fine work done by Gilman et al. Is looking at the diameter, the via of the Schlemm's canal via ASOCT. They looked at 5 sections in the eye which had iStent. One section directly over each iStent inject, one section, 500 microns away from each iStent Inject, and one in the opposite temporal limbus. And what did they find? That the diameter actually increases by about 75% next to the iStent Inject and almost 50% to the opposite limbus. And this was, of course, compared with control eyes. So what you're seeing here is a dilatation of the Schlemm's canal, which allows for better flow of aqueous physiologically out of the eye when you compare it to control. So when you first start, now I've done iStent forum talk, but that wasn't the East iStent forum talk. And so I will actually start by how I go about doing this surgery. It starts preoperatively. You have to choose the correct patient. You have to see the patient's angle thoroughly in outpatients. It's not that you allow someone else to do the gonioscopy, your fellow to do the gonioscopy, and then you do the surgery. No, you have to be aware how the angle looks. And it has to be mild to moderate glaucoma on visual field testing. So an ideal candidate for MIGS would be patients with mild to moderate glaucoma, and this should be on HVF criterion, should be open angle, IOP controlled on 2 to 4 drugs, undergoing cataract surgery. But you can also do it in uncontrolled IOP. Around 30 is just about ideal. Inability to take or intolerant to anti-glaucoma medication, and significant ocular surface disease. Now, a very major portion of my practice actually falls in these two categories, these three categories, allergic to anti-glaucoma medication as well. So why mild to moderate? I hope I have made that clear enough. They still have a functioning distal collector channel. So the TMB is an efficient way to open up these dormant channels. Do not need such glaucoma, do not need very low target IOP. And because it is limited by the episcleral venous pressure, you generally don't get a very low IOP. Then the visual fields has to be, the mild to moderate stage of glaucoma has to be determined by visual fields, nothing else. No, you can talk about CD ratio, you can talk about number of anti-glaucoma medication, but in my practice, I have OHTs who are on 3 or 4 drugs and who don't want surgery, or, whatever the reason might be. So it has to be primarily on visual field criterion, about 12, up to 12 decibels. So it is based on Anderson's criteria, but we've simplified it a bit, because if you've ever read Anderson's criteria, and you can go through it, I've given you the reference there, you will see that it also talks about any points close to fixation. Anyway, so the angle in angle-based MIGS has to be open even after LPI is fine. Practice should start in the OPD with an indentation type lens, not one of those 1, 2, or 3 mirror lenses. And you have to familiarize yourself with a wide variety of appearance of open angles. So you have a look at all of these angles. They're all open, but they're all very different. They don't look the same. So you need to know. The last one is an angle closure. Post LPI, you only see one goniosynechi, and the rest of the angle is open. So you can do TMB in these patients. Why indentation? I cannot stress any less that if you do see pigment, as you do see here, you should not jump to the conclusion that that is posterior trabecular meshwork, unless you're doing indentation type of gonioscopy. Look, after indentation, you can see that that pigmentation was actually pseudo PTM or pigmented Schwalb's, whatever you want to call it. And that PTM is visible, but only after you indent. And fortunately, no synechi there. So the incidence of ocular surface disease in glaucoma patients on anti-glaucoma medication is actually in excess of 50%. And there are lots of literature related to it. It's not unusual to see these kind of eyes in your practice on anti-glaucoma medication. What about allergies? Alpha adrenergics, they are mostly implicated, usually 8 to 9 months after commencement, and have been reported to the extent of up to 25%. Can also occur in CAIs to a slightly lesser degree, and itching is the predominant symptom. So here, this patient, he actually had a tube. He's unrelated to TMB, but had a tube, and I put him on a carbonic anhydrase inhibitor, and look what he got. He got cicatricial ectropin and an allergic type of picture. As soon as you take the patient off drugs and treat that, look how it reverts to normal. I was aghast to see his lids like that. I have never seen something like that with CAI before. I've seen these before, the dermatitis, the redness, the whatever. But once you stop the toxic drug, they dramatically improve, as you can see in this particular picture. What about this one? Patient on 5 drugs in the right eye, 4 drugs in the left eye, and a granulomatous uveitis as well. So I had to stop everything and put the patient on Diamox. And of course, one eye was very advanced, one eye was not advanced. So, I had to manage appropriately. So to summarize indications, it has to be mild to moderate on visual field criterion and has to be open angle. I don't believe in all the CD ratio business because I feel that, small discs can have a CD ratio of 0.4 and large discs can have a CD ratio of 0.8 and still be normal. 0.4 might be abnormal and 0.8 might be abnormal. So patients with difficulty taking medication, patients with side effects or complications, patients with poor compliance, intolerant to. Relative contraindications of TMB are synechial angle closure. Now, if you see a lot of synechi, there's no point in releasing so much synechi because it can always go and reform. And of course, I would never do any TMB in NVG, even uveitis, and lots of other secondary refractory glaucomas, and of course, even advanced glaucomas. So the second point that you have to remember practically is you have to learn intraoperative positioning. Now, many surgeons sit superiorly, some sit temporally. People have different habits. If you sit superiorly, you have to start learning to sit temporarily. You have to position the surgical table. It's always better to have a reverse Trendelenburg, which means that the head end should be up. You have to turn the patient's face about 30-35 degrees away from the surgeon, at the microscope 30-35 degrees towards the surgeon. You can, set marks on the microscope. So here, this is the very first iStent that was done. We're learning how to do it, setting the microscope just before the surgery was done. And I now routinely, I have placed marks on my microscope and I don't worry about checking it again and again. So the microscope tilt towards you, the patient away from you. That's how it works. You move the patient, ask them to look towards the nose. That's the best way to do it. And when you turn the microscope, just join the marks that I talked about a minute ago. So summary again, microscope towards you, patient tilted away from you. The third step that you need to learn is how to decide on an intraoperative gonioscope. To practice intraoperative gonioscopy first, learn to get an en face view. What do we mean by en face? It means you're at the level of the posterior trabecular meshwork rather than looking from on top of it. So view of the trabecular meshwork has to be en face. Here, you can see that you're not looking from the top, you're looking directly in line with the trabecular meshwork. So there are lots of intraoperative gonioscopes. This is iPrism SX. I quite like it. It sits very nicely on the cornea, and quite often it is hands-free. I don't need to touch it. This is Katina, and Katina is also a disposable one. It is rather small, very difficult to maneuver if you don't have a forceps in your hand. That it is also meant to be hands-free, but I find that it keeps moving on the eyeball a little bit. If you want total hands-free, then the Oculus system, the Gonio Ready system by Oculus is something you could invest in. I tried it on at WGC in Rome. Amit Pandey in Surat is using it regularly. And this is iPrism S. You have to hold it. You have a right-handed and left-handed version of it. It is semi-lunar in shape, and it's got open access in front. And at the very first iStent in the country was done on this particular um, gonioscope. As you can see, it's being placed and released. It is an L-shaped one. It's not like the Inject at all. And this is slowly being phased out of the country. So this is another one called Open Access. And of course, the good old Schwann Jacob. I used to use it. I'm not using it anymore. I feel that the view that I get with Schwann Jacob is in terms of field of view is inferior. In terms of the brightness in the angle, it is inferior. So I go for the newer ones. I Prism SX is what I prefer these days. Top tip that I can give you here is that you should be using good quality heavy molecular weight sodium hyaluronate as a coupling gel for intraoperative gonioscopy. If you use anything less, what happens is it just flows away and you have to keep replacing. So every single time that you lift your there is a movement, you have to lift again and place coupling gel again. So what I mean by that is that it should be that the high molecular weight OVD should be sitting on the cornea like this rather than flowing away. So here you can see I'm not touching it and it's absolutely coupled to the cornea, the iPrism SX. Then the fifth step that I would like to tell you is should be creating phaco wounds just slightly anterior to the limbus to avoid bleeding and poor view. Now, if there is a lot and you're worried about inducing astigmatism unnecessarily, then I would suggest you do a half keratome entry. Don't do a full keratome entry and use that for your iStent. If you're doing it prior to cataract surgery. If you're doing it after cataract surgery, then you could consider one of the temporal paracentesis to do. So you can do it any which way you feel comfortable. So here I am. I have finished. This is not a case of, but it's a temporal phaco. You can see I've made an incision which is not bleeding, but there are blood vessels that are coming up to the limbus. Why you don't want bleeding is because that gets mixed with your OVD coupling gel and then your view just goes for a toss. I would suggest that you practice intraoperative gonioscopy in routine phaco cases a priori under high magnification. Remember what you're doing for the magnification that you're using for TMB is much higher than you would be using for BANG or GAT or KDB. And use a blunt instrument, just stretch out your hand. Remember, because you're tilting the patient, tilting the microscope, your hands are much more stretched further forward rather than relaxed as you do as it is in phaco. So use a Sinski to get up to the trabecular meshwork. Even touching it a little bit does not matter. So here, this is a case of PACG, which has opened up post-LPI. And I'm demonstrating how you can go right up to the trabecular meshwork with Sinski. There are a few goniosyneci, as you can see, posterior to the posterior trabecular meshwork. Then, once you're ready with all this practice, schedule a dry wet lab session for iStent, which is what I did too before I actually jumped in and did the surgery. You have to understand the intricacies. I think this really doesn't matter anymore. iStent used to be almost parallel to the trabecular meshwork, whereas Inject and Inject W we know goes goes in perpendicular. And you can use, if you're all in Kolkata, in AIOS, they again have a dry lab. You can try all this there. Then learn to know your device, instruments, familiarize yourself with the box. It again may not matter so much anymore because iStent itself, the L-shaped device, is being phased out. iStent Inject no longer available. The only one available now is iStent Inject W. Then step 7 is to take the plunge only after steps 1 to 6. So you have to be really well versed with steps 1 to 6 before you move on. So let's look at a few iStent Inject Ws. These I've put up this case. Can you see the really homogeneous pigmentation in the posterior trabecular meshwork? Patient came to me pseudophakic. I suspected PDS, but concave configuration was not there, but the patient's pressure was not controlled, and the patient had significant OSD with drugs. So, sorry, I moved on. Very sorry. Yeah. So actually the video finishes even before you finish talking. So there's en-face visualization, as I was talking about. Then I go inferior first, because if there is any significant bleeding, then it will not obscure my view traveling down. So that is inferior one first. And then about 2 clock hours away, I do the nasal one, bang nasal. One is infranasal, the other one is bang nasal. You can see regurgitation. You want to see regurgitation because that tells you that your stent is sitting in the Schlemm's canal. Has pierced the posterior trabecular meshwork and is sitting in the Schlemm's canal. This is yet another case which I did, and this was a real oops moment. There was underimplantation. So I picked it out. You saw I went ahead and did the other one before I picked it up. Then I rethreaded it and injected it back into the eye. And you can see the two sitting next to each other, perhaps a little bit closer than I would have liked it to be. Now here, look at this case here. This has given me a lot of headache, actually. Fairly routine. Although there was hardly any pigment in the posterior trabecular meshwork, I went and injected inferonasally first. And then when I went bang nasal, it started bleeding quite a bit, mushroom bleeding. So I was a bit worried, did I hit the iris? But when I cleared out, I did not think I hit the iris, but it did bleed a lot, and it gave me a lot of trouble during cataract surgery. And even after that, after multiple washouts, you can see the blood in the eye. I think I washed out 5 times. What happened with her, unfortunately, is this. Very hazy cornea and blood in the AC. This is the first time that it's happened to me with iStent, any iStent. In fact, with iStent, I've not even seen blood in the AC it's a day 0 post-op, forget about day 1 post-op. And patient had microcystic edema, very high pressure and pain, and now very worried. So I had, because I was coming away for AIOC, I'm currently in Kolkata. What I did is I went in and washed out. The clot had become quite stubborn, used a vitrector finally, and took it out. But all that I was not so worried about. What I was worried about was the position of the stents and how they were looking. So what I did was, of course, had a view inside the eye. I don't know why I've not edited it better. There we are. Yes, that's for, I tried to use, they didn't get me the high molecular weight viscoelastic. So I tried to use HPMC, and that wasn't very good, but finally I did get. Now, what you see there is a tenting of the iris. So the inferior one, infranasal one, is actually blocked, and the other one is not visible still, but it will be in a minute. So I use a iris depositor, blunt instrument, and just gently tease away the iris, as you see there. And lo and behold, I could clear out as you can see there now. There we are. The view was not brilliant because of the haze in the cornea. And the second one, I wasn't sure what was happening, but there you can perhaps see there, and it's still bleeding a little bit. And I just didn't know what was happening. So I left some air in the AC once again, and story does not end there, unfortunately. She came back the day after surgery with intense inflammation. I was a bit worried there is an end off, but I shouldn't be getting, because I've not only left IC intracameral marks, but the patient has been put on oral antibiotics as well. So let's see how it pans out. I will keep you posted. So yeah, that's the original surgery, which did bleed and gave me a lot of trouble, and the patient a lot of heartache. So I'd like to share with you my data of iStent. Well, I've got all of it together, but I will talk about it separately also. Basically, I've only taken those that have a bit of follow-up rather than only a few months. As you can see, starting pressure 20.8 in the full group. Post surgery, last follow-up 16.7. So that's about a 20% drop. But what is very impressive is the drop in anti-glaucoma medication, and from 3.7 to 0.5. So more than 3 drugs. Of course, this is unpublished data. It will be published soon. So you can see the difference a little bit with iStent and iStent Inject. And I also found that the pressure drop with both seemed more or less the same, although my iStent Inject group seems to have a slightly lower anti-glaucoma medication. And iStent, these were the first few ones where I sometimes strayed into slight visual fields or glaucoma, which was slightly more than moderate. But now I'm a lot more careful about these things. So there you are. Medication difference between the two, but reduction in both nonetheless. So what I'd like to say before I end is that TMB is indicated in mild to moderate disease, and I cannot stress this any less, determined predominantly by your visual field criterion. It fills the void between medical management and more invasive traditional surgeries. And it appears to be promising, especially when there is anti-glaucoma medication intolerance, ocular surface disease, side effects in these kind of mild to moderate early glaucomas. And in its current form, it's not competing with TRAB, but then iStent Infinity is coming in. Infinity, it has got 3 stents, and may just be comparable to a TRAB. In iStent Inject W, conjunctiva is spared. In all MIGS, conjunctiva is spared, so TRAB can still be done if required. And it's easily combined with cataract surgery when a patient is on 2 or more drugs. And of course, you can use it standalone too. It's very useful when compliance and adherence is poor. What I like about it is that it's very patient-centric. It's not just TMB, but all MIGS, very patient-centric. Why? It's safer for them. With much lesser number of postoperative visits, early visual rehabilitation. Reduction of anti-glaucoma medication has several advantages. Eliminates issues of non-compliance and non-adherence. How many times we have to tell our patients to be compliant, encourage them to be compliant, motivate them to be compliant. But, it's quite often it's because of the recurring cost of the anti-glaucoma medication. And of course, when medications are reduced, it improves their quality of life substantially. So in my opinion, MIGS should be offered to all glaucoma patients undergoing cataract surgery in mild to moderate glaucomas, especially when there is AGM intolerance. Please don't leave them on 3 or 4 drugs. Please at least give them the option. Let them make up their mind. If you tell them it's safe, believe me, they actually catch on to it pretty quickly. Okay? Of course, cost may be a limiting factor. Thank you. Why to intervene early? I like to tell them that I want to reset your anti-glaucoma medication clock. What does that mean? Over a period of time, your medication has been stepped up. So what I want to do is to try either eliminating it completely, give you a drug-free period, or give you the least minimum that I can give you. It improves your quality of life. And because of its excellent safety profile, in controlled glaucoma, additional IOP reduction with reduction of AGM is achieved. And reoperation rate is not very high. In literature for, let me just recall this, Paul Healy literature, where they've talked about standalone MIGS, not even combined with cataract surgery. They have reported at least a 30% reduction at 5 years, and at least one drug reduction at 5 years, and a 2.2% reduction reoperation rate only. So the more you do, obviously the rate goes down. Thank you very much for a very patient listening. I'm happy to take questions.
Thank you very much, Doctor, for an excellent presentation today. And I think now we have a couple of panelists available. Dr. Shantanu Ganguly is there, Dr. Debashish Chakraborty, and Dr. Tayab is there. If you have any questions and discussion, you can.
I have tried the questions that you gave me. I tried to address them in my presentation itself. But if anyone has any further doubts, please feel free to.
Thank you, ma'am, for the wonderful presentation. It is very it's an eye-opening thing. And one thing I'd like to know about that while filling the anterior chamber with visco before going for the procedure, is there any calculation of the cohesive and dispersive combination, or should we go for cohesive only, or fill as much as possible, or selectively at the site of the TM, which which will be better so that it doesn't collapse while
See,
going through?
I would go for a cohesive only, unless you need to protect the cornea. But when you're doing iStent Inject, you're not using any power. So you really don't need a dispersive at all. If you want to use a dispersive later when you're doing your phaco, that's your choice. But you ask me, I like to fill up the anterior chamber completely with a cohesive. I am actually now tending to do, unless, of course, the view of the angle is not very clear, and I get that information in the OPD itself. What I tend to do is I tend to do the MIGS procedure, whether it's TMB or whether it's KDB, before I actually do the cataract surgery. But believe me, view is much better after. If that is what is more convenient for you, please do so. But sometimes what happens is when you get a very advanced nuclear sclerosis and you're using a lot of power, your wound is hydrated, your view goes down. So you have to judge yourself. What are you going to do? If the cataract is going to require much more phaco energy, and you run a risk of having a white phaco wound, whitish phaco wound, that reduces your clarity with the intraoperative gonioscopy, then do the procedure first, do the MIGS procedure first, and then do the cataract surgery.
Thank you, ma'am.
Ma'am, I am doing KDB. I have not been able to do iStent till now only because of the financial issues.
Right.
Yeah, so
But
I'm
you do know that, so far, the majority of patients I've done have actually been on no, actually, I lied. Recently, I've done quite a few cash actually, but it's fully reimbursed by insurance. So if patients are on insurance, you shouldn't let the chance go by.
okay.
At least try.
Yeah, maybe I actually I think I haven't got that kind of patient. I mean, who are like, having the insurance.
I see. The
Yeah.
demographics are a little different. Yeah.
Yes, yes. So
Okay.
basically, I'm actually waiting for patients who comes to me with the request that yes, go ahead and do the iStent. Because
Yeah.
yeah, so then it
Becomes much
becomes easier.
easier actually
Yeah, ma'am. Yeah.
when
Rather than me convincing them to do something which is so costly, it should be the other way around. So I'm just continuing with the other angle surgeries, but
Mm.
iStent so far I haven't found the right patient.
Well, the only difference is, of course, that you have to do it at much higher magnification. That's for sure. And there are certain uh, not side effects, basically certain issues that are very peculiar to iStent Inject alone. That is over implantation or under implantation, or a blockage. You saw that bleeding. I mean, I've never seen bleeding like this in an iStent, never. So
What could
when
be the bleeding be due to, ma'am, in this case?
I'm at a loss to explain. I don't know whether there is some aberrant vessel there, from the surface, which I can't see. I don't know. I cleared out, this, I did it only on Monday because I was at another campus on Tuesday, but I still came back to see her post-op and she was filled with cells in her AC. I was so worried. No blood, but yeah, and the vision had not improved. I'd done her other eye, and she was a high myope, whatever you want to call it. I think her power was, I think, -22 or something. She was so happy. She's 6'6", unaided distance vision. Near, of course, is not brilliant, as you know, will not happen with a monofocal. But she was thrilled. Within 3 days of her first eye surgery, she came and told me, I want the second eye done. And she's having all these troubles with the second eye.
Is there
And
any scope of, ma'am, explanting it and then replanting it in some other site if you are suspecting an aberrant vessel?
well, at some point it's supposed to stop. No, it's
Yeah.
not bleeding now. It's not bleeding now. Not I don't see. I've not put a gonio lens on yesterday. I did not put a gonio lens on yesterday, but there is no blood in the anterior chamber. I'm hoping it is fine, and I'm hoping that the blood will not stay there. It will be cleared by the body, as it does. But it's just that it had bled so severely that the clot was not moving away. And because the clot was not moving away, I had to go in and do an AC wash. And obviously the other stent was also blocked. So I don't know why she reacted, why the AC reacted so in such a dramatic fashion. But anyway, she's also steroid responder. So you have to keep everything in mind. Third day, after first eye, she was 6'6", and her pressure was 15. She was over the moon. No drugs. And the day she came for surgery for the second eye, she said, my vision is a bit blurred. And when I saw her in OPD, obviously she was still on steroids in that eye, pressure was 28.
Okay.
And then so it definitely, steroid response, inflammation, all these things in the post-op period add up to, management dilemmas, what to do. So right now I have said everything is temporary. First thing I have to tell her is everything is temporary. Otherwise she will not do. She's that kind of a person. So I told her, I gave her Diamox. She hates Diamox, but I had to give her Diamox because and I gave her some topical also. She's not happy that I have not given her a prostaglandin analog, which is once a day. I said, no, in inflammation, I can't give you that.
Ma'am,
So,
I have a question, ma'am.
yes,
Vanita, ma'am.
yes.
I am Dr. Purnima. I have a
Yes.
question.
Nice to meet you.
In trabeculectomy, usually we should not give Diamox, etc., estazolamide,
Yes.
because the may block. And in iStent Inject, suppose you have so much pressure is very high, you should give Diamox or you should not. How many days you should give Diamox also?
No. See, the
It is because
principle
the
of any aqueous suppressant in
yes,
a trabeculectomy versus a trabecular micro bypass is very different. So in a trabeculectomy, what is happening? You are creating an ostium under a flap, and your drainage, your filtration depends on whether that flap is separated from the bed of the sclera. So if you give aqueous suppressants, there is nothing that can flow under the flap. And so the flap will stick to the bed. And so even if your ostium is patent, your trap will fail. So that's a different principle. The principle here is determined by your episcleral venous pressure. Yes, if you give aqueous suppressants, your IOP and your episcleral venous pressure may more or less become equal, and nothing may flow out. But as soon as you stop it, it will. However, if you're giving at a pressure of 40, obviously you need to reduce it, isn't it? You cannot.
but it may block the iStent.
Sorry?
It will block because the blood
No.
blood
This
is
is not a
hypema is there, and pigments are
you are
not block that iStent.
you are not making a manual channel. This is a non-ferromagnetic titanium implant. Okay. So it should not get blocked.
Okay, okay.
In fact, yes, pigment can block it, but the body may clear it as well. If the body doesn't clear it, then you can use a little YAG to tickle it. That's it. But you have to see that under high magnification. So the dynamics of a macro filtration versus a micro filtration like this are very different. Depends on different.
How many days, madam, you want to give in this case? In second eye you operated. How many days you will give Diamox? See the cornea. Cornea looks very clear. Initially it was edematous, but it looks when you give in air, it is.
Yeah, because I gave mannitol.
Oh, that's
I
right.
will not enter the eye with a pressure of 40. Never. Okay, I gave mannitol. No, post-operatively, it was clear in the sense there were cellular deposits. There were KPs and there were cells in AC. There was no hypopian. If there were hypopian, I would have freaked out there and then. But
That is right.
no,
But
there was
maybe
no.
TAS, hypogen may be due to TAS, etc.
Yeah, it could be TAS. There was no hypopian. There was no hyphema, no
Yes.
hypopion yesterday. Now, we'll see what there is in store. I mean, as and when the inflammation comes down, I am going to take her off the potent steroids that I've given her. Once I stop the potent steroids, I will take her off the Diamox completely. Then I will wean her off the anti-glaucoma medication also. So that's why I said it
Oral
was
steroids you have given? Oral steroids or only topical?
no topical, only topical.
Ma'am,
Yeah.
what is your regular
Thank you.
post-op regime for iStent with cataract?
Very good question, actually. And this is something I have devised myself. What I do is in the first week, let's start again. Whenever you are doing MIGS surgery, remember your trabecular meshwork is still in play, whatever is left. Now, in iStent Inject, of course, the majority is still in play because you're not destroying anything. All right. Even in KDB or Bang or whatever, the rest of the trabecular meshwork is still functioning. May not be functioning as well, but it's still functioning. So the chance of steroid response is very high. Very, very high. Okay. Therefore, what I do is in the first week where steroid response generally does not manifest, I give very high potency steroid to quickly get inflammation controlled. So I will give 2-hourly difluprednate for 1 week. Yes. And then at the week's appointment, if there is no inflammation, it is stopped completely and I change it over to loteprednol 4 times daily. I have seen patients react on loteprednol as well. Not as much, okay, but, pressure of 22, 23, and then I stop the lotepred and the pressure comes down below 20. Yeah. And how do you know? How do I know that the pressure is actually it's steroid response? Is because every single time I will also check the pressure of the fellow eye, and the pressure of the fellow eye also goes up. That is the best way to find out whether or not there is steroid response. So once I stop,
Lotepredman, ma'am, how many weeks you continue?
I give about 4 weeks. 4, 3, 2, 1 is my general.
4, 3, 2, 1.
Yeah.
Okay.
With
So
that, of course, and antibiotics. I don't give pilocarpine in TMB, but I do give pilocarpine in KDB. I have seen. Otherwise, you tend to get PAS formation. Yeah. So, despite pilocarpine, also sometimes you can have PAS formation. But if there's enough of the Schlem's canal, which is approved, then your pressure control is pretty good.
Pilo, ma'am, how many weeks we have to give? 2 weeks or should it be more?
I generally never give more than 4 weeks unless there is an actual need for it.
Okay.
Sometimes I just continue for a little while at bedtime, once a day. I start with 3 times. I keep reducing. Also, remember that, Pilo will control the pressure to a certain extent. So you want to make sure that they are okay to be, off the Pilo completely. So, yeah. That's the advantage of Pilo. Yeah.
Ma'am, is it necessary to stop the anticoagulants before this procedure?
Yes,
iStent?
absolutely. Absolutely.
Please
Because
stop before.
yeah, I stop anticoagulants. Also, one of the tips that I can give you is do the inferonasal one first, so that if there is any bleed, it goes down rather than obscure your view. If you do the nasal one first, that will trickle down and that will obscure your view for the second one. So it is better to do the inferonasal one first. This is something Shutana was asking me the other day, and I told him that this is how I do mine. Yeah. There was also a question about over-implantation or wrong implantation. Implantation in, say, the scleral spur or implantation in the iris. Now, if it's implantation in the scleral spur, which is not meant to be a vascular structure, you can easily extract it out. You can use and very useful in your practice would be to have curved intraocular micrograspers. They're very useful. If you have them straight, what happens is by the time you get to the angle, you're distorting your wound, so you lose your AC. If you have it curved, then there is no distortion of your wound, and so your AC is maintained and you can easily grasp it out. Keep high density molecular weight viscoelastic on, say, a plastic wrapper, maybe the cover of a suture or something like that, white background, as you saw in my video there, and then drop it in there so that it does not flow away, and then rethread it and then go back into. The other thing I do regularly now is what is available now in our country, the Inject W has only 4 clicks. You're using 2, and 2 clicks are still there. What do we mean by these clicks? The click to inject. So what I do is I ETO and keep them just in case I need them. In future.
Yeah.
So you learn from your own experience as to what you should be doing. But you have 4 clicks now. iStent Infinite, it's not called infinite because you have infinite iStents in it. It's called infinite because you have infinite number of clicks in it. So you don't have to worry about it at all. And it has 3 injects in it. And so therefore, their trials are going on comparing it with Trab. So it's more comparable, possibly. Anything else?
Madam, excellent presentation as always. I
Thank
just wanted to know 2 things. One is, what are your tips for viewing an angle where the trabecular meshwork is not very pigmented? And number 2 is, after doing the surgery, after how many months do you usually feel that now you have got the optimum result of the iStent?
Yeah. See, with regards to your first question, what I have found, as with this high myopic lady, she had very sparse pigmentation in her trabecular meshwork, and I was ready with trypan blue to stain the Schlemm's canal, but I didn't need to. As soon as there was viscoelastic in the AC, and as soon as I placed the gonio lens, there was regurgitation in the Schlemm's canal, and it was lighted up as red. So I could use it, but you can use trypan blue staining just as easily. Not a very a dilute solution would be much better than having what you normally use for staining the capsule.
Yes.
That's a trick you can use. And secondly, sorry, what was your second question, Devashish?
How many days?
Sorry. Yeah, how many days do I feel that I'm a firm believer that once you do a procedure for glaucoma, you should be stopping all the medications, and that's what I do. From the day of surgery, patients are not on any anti-glaucoma medication. If required, and if I feel they have not had a steroid response, then I will add medication. But if by 1 month, which is the maximum, usually the maximum washout period for most drugs, most anti-glaucoma medication, if by 1 month I don't need any anti-glaucoma medication, I have found that that is a success. Complete success. And that's how I do for all my MIGS, not just TMP. I stop on the day of surgery. I do a lot of ECP. The only thing about ECP is that because you go in the sulcus and you use a again high density molecular weight OVD, the clearing out is not that good. The aspiration is not that good. So you tend to get a spike within 2-3 days. So I keep them on Diamox for 5 days. 3 to 5 days is what I do. That's it. Nothing else.
Ma'am,
Yeah.
ma'am, regarding the ECP, you said the clearing is not good. Is it because of the instrument or?
No. Because you're not in the angle. You're in the sulcus. You're
Yeah.
bumping up the space between the iris and the anterior capsule. All
Yeah.
right.
Yeah.
So clearing out any OVD from there, very, very difficult. You're not seeing it, no? Endoscope is to see the trabecular, to see the ciliary processes. But once you're doing aspiration, irrigation and aspiration, no matter how well you think you have cleared out, you can still get a spike. And that's because it's a very because you're using I use a viscoelastic which is sodium hyaluronate 1.4%. It is by a company called Biotech. They actually import it, but they sell it very reasonable price. Very reasonable. It's called BioHyalar and BioHyalar Plus, sorry. And I'm really very happy with it. I don't use Helon 5. I don't use Helon GV. They are very expensive. They just add to the cost of the surgery. Already the surgery is very expensive. Anything else I can help you with?
So I think, Doctor, we have already now around 9:40, and I think we have a very good discussion, decent discussion, and our all panelists have able to understand lots of the points from your vast experience of MIGS. So I would like to conclude the session if there is no further questions from anyone. So that's all, Doctor. Thank you very much, Dr. Vanita. I think it was a really a great meeting, and this part of India, doctors are starting the MIGS, though you are 2 steps ahead. The other part of India is 2 steps ahead, but this is we are a little behind, but will not will not be like this in the coming days. Yeah. So thank you very much for your time today, and it was a great discussion altogether. I would like to thank Dr. Tayab for her time, and I know this is a family time, but thank you very much for getting your time out and be a part of this event. Dr. Shantanu Ganguly, thank you very much from Siliguri. I think really appreciated your presence today. Dr. Devashish Chakraborty, thank you very much. Thank you. Dr. Chakraborty also, and Dr. Purnima, who are the joins that there are a few other doctors have could able to join because of the AIOC tomorrow. Today there is some presidential dinner has been posted. So I have got some SMS that now the other panelists not able to join because of this dinner party. But I think this is a great event altogether, and thank you very much everyone for this wonderful meeting. Have a nice day. Thank you very much. Good night to everyone.
Thank you.
Thank you. Good night.
Thank
Thank
you.
you. Good
Yeah.
night.
Good night.